This is Dr. Marnie Peterson. I am the Outreach Coordinator for the Antimicrobial Stewardship Project, launched last year by the Center for Infectious Disease Research and Policy at the University of Minnesota. It's my pleasure to welcome our participants to today's webinar, which is titled Designing Stewardship Interventions Robustly to Plan for Scientific Dissemination. This is an important topic that we're excited to have presented by infectious diseases expert Dr. Elizabeth Dodds Ashley. Before we begin, a little bit of background for those of you that aren't familiar with Dr. Dodds Ashley's work. She holds her PharmD and a Master's in Health Sciences. She's an Associate Professor of Medicine and a Liaison Pharmacist with the Duke Antimicrobial Stewardship Outreach Network, otherwise known as DASIN, based at Duke University. She's been an active antimicrobial stewardship pharmacist for more than 15 years. Her work and research in stewardship span a variety of patient care settings, including large academic centers, medical centers, community hospitals, and long-term care facilities. She served in a number of numerous roles as an advisor, being part of the Antimicrobial Resistance Working Group at the Centers for Disease Control, and an expert panel member of the Transatlantic Task Force for Antimicrobial Resistance. She's active in several professional societies, notably SHEA, the Society for Healthcare Epidemiology of America, and SIDP, which is the Society of Infectious Diseases Pharmacists, where she also serves as their president-elect. I would like to thank our participants for joining us today, and I want you participants to know that at any time we would love to have you engaged in our webinar. You can submit questions and comments to Dr. Dodds Ashley, otherwise known as Libby, via the WebEx chat box located at the bottom right-hand corner. And we'll also have time at the end of her seminar where we really want to engage and hear from you during our question and answer session. I want you to also be aware that your lines will be muted during the webinar, and that this webinar is actually being recorded and will be available after today on our YouTube channel. So with that, I'd like to welcome Dr. Elizabeth Dodds Ashley to present her webinar on this important topic, and to also mention that in our May poll that we posted on our CIDRAP Antimicrobial Stewardship website, this topic was actually important to over 35% of, deemed important by over 65% of those responders. So it's a very important topic to our stewards that visit our website. So thank you, Libby.
Thank you very much for having me, and thanks to everyone for listening in. I'm able to see the attendees on the line, and I see very many local colleagues here at Duke, as well as colleagues from across the country who have equally, if not much more experience in this. So please chat in your comments and suggestions as well as we go through. What I hope to do during this webinar is take you through what I intend to be a very practical example of how we can apply some of these research principles. I know all of our pharmacists and physician and nursing colleagues get training in research design as they go through school, but I think sometimes many of us struggle with taking the leap into making that practical and really thinking about it when we design stewardship interventions. Because I think this is what happens to many active stewardship groups. We've all been there, right? So you sit down at the stewardship committee and you're at step one. There's a problem. Antibiotic use is up. Maybe C. difficile is up. We have to do something about it. So we get around a table with all of our experts and we come to a conclusion of what we can do to solve this problem. We design a stewardship intervention. We talk about what needs to be done for it. We come up with education. We go through the committee process. We write policies. We do all of those things. And then we get ready to implement. And there's a big go live day, and we launch our initiative, and we're very excited. Once it's up and running, we track it with time. Maybe it appears on a dashboard or a quarterly report that gives the hospital administration, and maybe the use or the infection is down, and we celebrate. Everyone's super excited. And as you see here in step 5, it's great. And what often happens with stewardship interventions, it's at that point that someone will say to you, those results are fantastic. You should think about publishing them, submitting them to a conference, studying it further. We should take this somewhere. Unfortunately, so many decisions have been made by that time point, and so many data points have sort of gone underneath the bridge that we can't go back and recreate them, and it becomes difficult. And what we end up with are suboptimal representations of the stewardship work. there have been lots of recent publications. I think one that comes to mind is the Pew publication on antibiotic use in U.S. hospitals that came out earlier this year in March that really talked about the need for us to better study stewardship and what we're doing. And I think the way that needs to be done is, one, through large studies, which I know many of you work on, but also by empowering the local stewards to better study and think about what they're doing as they design and implement these stewardship interventions all across the country. And I want to pause and challenge you to think about this. So I showed you the normal process for how at least most stewardship interventions I've been involved with get designed and implemented, and then there's a plan for studying them. So what steps are missing in our stewardship intervention design process that would ensure easier dissemination at the end, and not that sort of uh-oh moment at the end where you say, oh, what do I do now? Or, which is also very common, and we see a lot, as we're approached by various trainees, pharmacy residents, medical residents, students from various disciplines who come and say, oh, I really need a project. And we often sit and think, oh, we've been doing this great stewardship intervention for a while. Maybe we can come up with a way to study that. I think that if we were better at thinking about this and really implementing a purposeful plan to disseminate our work when it's done as we're designing the intervention, we'll see better research being published as a group. So let's go back to our process. Perhaps what we need to do is earlier on say, what is our goal? And you might say, well, of course we have a goal. We have a problem. We're trying to solve the problem. But I don't know that, at least I will confess, I've not always done a great job of sitting down and stating what our goal is and what specific outcomes we're going to measure beyond the very basic use question that often is what prompts us to implementing one of these stewardship interventions in the first place. Sometimes we're actually addressing a problem. Perhaps it's a rise in C. difficile, and we'll continue to track C. difficile, but our stewardship interventions might be very focused. So, for example, they might target around fluoroquinolones, and at the stewardship team, that might be just what we looked at, is the fluoroquinolone use down. And I think we really need to pause and do a better job of saying, what are our outcomes for this particular intervention? Because one thing for ensuring dissemination of our work is often we're going to need to track more than one outcome, and we need to think through this. And I want to spend a few minutes here just talking about various stewardship outcomes, and I want to go over a study that I participated in here at Duke that was run by my colleague, Rebecca Mooring. This is, it was called the Stewards Project, and it was designed to look at metrics and assess them for utility in describing stewardship interventions and stewardship activities. I'm going to briefly go through this here, but this was actually the topic of the CIDRAP webinar in March of 2017, and it can easily be accessed on the YouTube channel for the program, which there are great links to right off the main website. If you just look there, you just go and find the webinars, and it was the March 2017 installment. But just for those of you who may not have heard that presentation, what happened as part of that project is we went through the literature to look at metrics that had previously been described. They didn't necessarily have to have been used. They could have been used, or they could just be proposed as good metrics for antimicrobial stewardship. We looked through a ton of different metrics to come up with 691. That was a lot of reading, I promise. And then we collapsed them down, took out duplicates where things really overlapped, and had a group of 90 that we took forward into a modified Delphi process. And there, we sent these metrics out to expert teams. Our panel included physicians and pharmacists, as well as some other experts in stewardship, and they assessed each of these for 4 different questions. So these were, what is the metric associated with improved antimicrobial prescribing? Is the metric associated with improved patient care? Is the metric useful in targeting stewardship efforts? So it might improve patient care and also be associated with antimicrobial prescribing, but it's not going to drive stewardship efforts. So that was something we asked the panel to discriminate against. And then lastly, is the metric feasible? And the way this went is we started with 90 and we took through 2 rounds of rating through this survey. And after each round, there were extensive discussions held with the panel where we helped weed out various candidate metrics to decide what would go forward as our final list of recommended metrics for assessing your stewardship intervention. This is the the final groupings, Group 1 and Group 2. So to get into Group 1, which were deemed ready for immediate use and tracking, you had to have positive assessments on all 4 of those questions I mentioned. So associated with improved antibiotic prescribing, also patient care with drive stewardship interventions in a meaningful way, and were easy to measure, or feasible to measure at least, maybe not easy. We had divided our metrics into 5 different categories. We eliminated the financial metrics pretty early on in the process, and that left us with clinical outcomes. And although so often I hear a call for a good clinical outcome that we could all immediately implement and assess in our stewardship interventions, none of those made it forward to Group 1. There were some unintended consequences that included C. difficile, as well as other drug-resistant infections, antibiotic use, using the days of therapy metric, and various denominators based on what's available and feasible. And then process measures is looking at use of antibiotics where spectrum might be redundant. So trying to categorize what we also call the quote-unquote never events. There were a lot of additional metrics that met 3 of the 4, so everything except feasibility, which would be, so the panel felt these would be meaningful metrics to track if it were just feasible to do so. And I show you this because there's a lot of examples here of things you may want to incorporate into stewardship interventions that you're planning. Our feasibility metric specifically addressed whether it could easily and quickly be done in an electronic health record. You may look at these, and there might be great ways that these can be incorporated in the old pen and paper or more manual data extraction methods, which are great. And there are also a lot of work going on around the country that is trying to assess these various outcomes using electronic means. And so stay tuned. There's a lot of great information that might be coming in the future on various methods. I know a lot of different groups are trying to do this and having some success. So that is something I hope to see a lot of advancements in the future. But there are a lot of great proposed metrics and outcomes we can look at for our stewardship intervention so that we might want to include in our research to be sure that we have this. As I already mentioned, you likely need more than 1 outcome to have there. And one of the reasons for this is something that's often missing. So here's a list of candidate outcomes. You can probably look at there and think easily of things you might want to track for your stewardship interventions. But I think what we miss are additional outcomes and measures. They look a lot like the clinical outcomes you might be interested in, but they're used as balancing measures. You know, a lot of what we're trying to do in antimicrobial stewardship, as you know, is decrease the unnecessary use, but not cause any unintended harm to patients in the process. So I think it's also important that we can commit. You may not set out to do a stewardship intervention and have any hope of seeing a change in mortality because you're shortening duration of therapy, but you definitely want to measure mortality and make sure you're not worsening that metric. So these balancing measures are really important to consider, and I think are very valuable to have as a discussion at that stewardship table. When you're designing and implementing it, the various stewardship interventions, to talk about what are the perceived risks. What are the things that we might be doing as an unintended consequence of this new stewardship intervention? And there are lots of examples for lots of different types. I think just to give you some concrete examples, I know a lot of institutions already have IV to PO, and one of the concerns that always gets raised is, are we having to unnecessarily put patients back on IV therapy a lot? That might be something that you look at to make sure we're not having to convert back in patients. Perhaps you're going to look at length of stay, because if patients are being switched too early to oral therapy, they might have to stay longer in the hospital because they didn't respond as quickly to their infection as they might have otherwise, things like that. So in addition to the outcomes of interest in terms of what you're trying to change with your stewardship intervention, be sure you also have these balancing measures as part of your initial plan. And I think to really take this a little closer to home, what I want to do with the rest of our time is jump into a case study. And for the purposes, I know that with stewardship groups, we can easily spend lots of time talking about what the best stewardship intervention might be. But here is some example data. You get a benchmark report, and your use of meropenem is by far and away almost 3 times higher than any other facility in your network, or maybe than any other unit in your hospital, or however you're measuring your antibiotic use. And I will give you some additional facts about this. So we knew meropenem use was high. We also looked at it and found it was highest in the intensive care unit. We looked at the percentage of patients that started on meropenem, and it's similar to other facilities or units, but our duration is long. So our days of therapy with meropenem is long, and it seems to be driven by the overall duration. And that's your problem that you've identified. You've sat down as a committee, you've asked those additional questions, you've gotten the information, and you've decided that the intervention you want to put in place is ICU rounding by the stewardship team daily with the ICU providers to see if you can help optimize durations of therapy. So before you want to talk about it too much, stop and just answer for yourself. So what is the goal of your intervention? You might say, well, if you told me my durations are too long, obviously we want to see a decreased duration of therapy for meropenem in our ICUs. We might want to see decreased overall meropenem use for our facility or our ICU specifically, if that's how you're measuring it. I would argue, though, that we also need to have some additional outcomes. So what are some of the balancing measures? We want to make sure that ICU length of stay isn't changing and going up as a result of the intervention that we've put in place. If we have these rounds and we're going to see decreased total duration. I think as another balancing measure, we want to look at overall antimicrobial use in our ICUs to make sure we aren't just, sure, maybe we're getting patients off of meropenem, but we know meropenem is the drug of interest, so we're just shifting them to a lot of other drugs. Maybe they're getting different combinations with cephalosporins and other agents to cover gram-negative, for example, instead of meropenem. So you'd want to have those measures as well to be balancing measures, and I'm sure you can think of many more. So it's important to stop and say, what are all the things we might want to measure? And I think that's it seems relatively minor, but it's such a key step that's often missing in the design of a stewardship intervention that precludes it from being useful and able to be disseminated once the project is finished beyond just the local committee use. You may nicely show that you decrease the length of therapy for meropenem in your ICU, but you don't have those other measures to really make it valuable to the external reader. So we've picked our stewardship intervention, we've decided on some outcomes, and now we need a plan. And I know there are many different study designs that are out there. I want to go through each of these 5 different study designs with you over the next several minutes to talk about the pros and cons, specifically in the light of the stewardship intervention. And we'll keep in mind this meropenem example and our ICU rounds as our targeted intervention to try to see what we can, to see what might work best. So let's jump right in. I will say that the basis for a lot of this, and if it's a paper you haven't read before, I highly recommend reading Justina McGregor and J.J. Faruna's paper that was in Supplement to Clinical Infectious Diseases in 2014 that goes over various study designs really in the terms of stewardship and takes a much deeper dive than we'll be able to here in the course of this webinar. But let's start first. I think a lot of people want to do a randomized control trial. I work with a lot of pharmacy residents, and it's that time of year where we're working on designing their projects, and many of them come to me and say, I really want to do a randomized control trial. Obviously, there are a lot of advantages to this. By randomizing patients, we control for confounders. We are being prospective in what we're doing to the individuals. We usually randomize at the level of an individual. So the example using our ICU example is perhaps what you'll do is decide that you're going to do a randomized trial of ICU rounding on various patients. And there is some randomization scheme, and it actually dictates which patients the stewardship team will round on at any given time. You do have to worry about some things, like it might be hard to actually do that. There might be too much confounding introduced by that because it's the same team of providers that you would be working with, for example. So maybe you decide to randomize. Maybe there's 2 teams rounding in your medical ICU, and you randomize to a team to provide this added level of review so that you have comparative patients. But there can be logistical barriers. There is a high level of regulatory review. You absolutely need the IRB involved. But it does have some nice because it does control for confounding better and assures 2 equivalent patient populations at the end of the day, which is why you do the randomization. These are considered the gold standard of research. But few antimicrobial stewardship projects or interventions that are assessed really do have a randomized control trial. It just doesn't, it's not very amenable to most stewardship interventions where they're truly quality improvement initiatives, and we don't want to limit our work to just a targeted sample of patients because we're trying to change something and improve the quality or change the C. diff rates for example, in our patients. So we don't want to take the time to do a randomized control trial. I want to implement the stewardship intervention and then use different methods to study it. But there are lots of others. So one is the cluster randomized control trial. So you might, this is where you might randomize different units, or I work in a network that has 28 different hospitals, and so we do some studies where we do cluster randomized at the hospital level. So you have a group of patients who are similar for some reason, and that's your cluster, and you randomize at that level. So you can compare outcomes between those groups that got the intervention and those who didn't. So maybe you work in a facility that has lots of ICUs, going back to our meropenem in the ICU example, and maybe you randomize ICUs to receive it. Maybe you randomize months where they're going to receive it in the various ICUs. And again, you get the advantage that randomization controls for some of your confounders that may be known or unknown at the cluster level. So the nice thing here is you may not even know all the factors that might be confounding your meropenem use, but by randomizing, you should hopefully be controlling for those, and that's the purpose. Something you do need to have larger numbers of patients to do this, and it can be very difficult to standardize the intervention across various clusters. So when our cluster unit is at a hospital, for example, it can be difficult to do things similarly at all the various hospitals, depending on what they are randomized to. So there are also potentially some, at hospital level, even at unit level, some important differences that might be need to attempt to control for in the analysis. So for example, if you're in a hospital that has 2 medical intensive care units, there is probably some detail behind the patient selection that goes to one unit versus the other. And it might be difficult to fully control for that in your analysis, but those differences may exist that are just out of your control. Sometimes we want to use the clusters or these units as their own control, and that's where we might get into the next type of study design. And this is important because you might be saying, well, I'm trying to do this from the standpoint of a stewardship team, and I don't want to sit down and write a full protocol and true study. But knowing these principles, you might decide how to implement your stewardship intervention differently. And so this is another way that we try to assess various interventions. So cluster randomized crossovers, and I'll have a graphic for this in a moment for you. This is a 2-phase study where clusters, so hospital units, full hospitals, are randomized to an intervention phase and a standard of care phase. And the randomization dictates which order you get these in. And sometimes we've even done cluster randomized crossovers where we compare 2 different types of interventions. So everything is an intervention phase, but it's intervention 1 versus intervention 2 with a washout. And then you compare outcomes between the 2 interventions, or the intervention and the standard of care. So again, because there is a randomized component to this, you are controlling for confounders that occur at the cluster level. Each cluster serves as its own control, so it takes away some of the concerns about differences between clusters, and that's important, for example, when our cluster level is at the hospital. But again, it takes a large number of patients to do this, and when you think about trying to roll out a stewardship intervention, if your cluster unit is different hospitals, it can be difficult. So let's jump to this graphic, and I'll talk about some studies that we've been a part of just to make it a little bit concrete. So sometimes there might be retrospective data, and then hospitals are randomized. And in this case, it was 2 different stewardship strategies. At some hospitals, one intervention was restriction, and one intervention was prospective audit. Now think about all the different ways you may have seen this implemented at hospitals you work with. So this is what I mean when I say it's very hard to standardize the stewardship intervention. So if you're trying to do restrictions, some hospitals may or may not have infectious diseases available on call 24/7. So some hospitals may have restriction done by infectious diseases physicians. Some may rely on restrictions done in the pharmacy. And depending on the size of the hospital, the pharmacies may or may not even have staff present at night. So random restriction may occur overnight, and it may not. It may be all doses overnight are allowed to go forward, and then they're reviewed in the morning. So it can be very hard to have standardization across your various different clusters. You may say, well, I just work in one hospital. I won't have that variation between facilities. But even think about differences between units. Maybe different units in your hospitals have pharmacists rounding versus don't. Some may rely more on automated dispensing cabinets for distribution of drugs, and it still might be hard to really standardize across the different clusters when you go forward. So then when you move from stage to stage, there's usually a washout period. feel like the most common one I see is a 1-month washout period, and then each cluster randomizes to the intervention they didn't get in the first stage where they were having the various interventions. So this is a great strategy that gives you the ability to look at that unit or facility level, to be able to not worry about things like once you start talking to providers about various interventions, you don't have that bias that they will then apply it to subsequent patients who may or may not randomize to your intervention. So it's a good unit to randomize. And using this crossover design, everybody gets to serve as their own control, so you eliminate some of the concerns with differences between the various clusters, be it facilities or units in your hospital. I also want to talk about non-randomized control trials. We get asked about these all the time. So there is an intervention that was rolled out, and so perhaps you have decided that for our meropenem intervention, you want to implement this in your medical ICU. And there's reasons for that. But you also want a control group. So perhaps the only other intensive care unit in your facility is the surgical ICU. And you might say, well, can we compare to the patients in the surgical ICU? It gets a little tricky, but that's exactly what a non-randomized control trial is. So you have two different groups, and the intervention assignment is based on some factor that is not random. So there is a reason you are picking that unit. Maybe you can't functionally implement stewardship rounds in your surgical ICU because they round at 6 in the morning and you don't have stewardship staff there to do it at that time. This requires a little bit more robust analysis in terms of you have to be able to control for known potential confounders because you don't have the convenience of randomization and theory taking care of that for you. That requires a little bit more statistical help. Sometimes the analysis is not quite as straightforward, so you may need more assistance doing those analyses. The other thing is that there may be confounders that you don't know about. There may be reasons, and I'm sure you can think of many reasons that you would want to control, many things you would want to control for. So, for example, in a medical ICU, perhaps patients are in the hospital longer before they go into the medical ICU compared to a surgical ICU where it's mostly post-operative patients. So that's a known confounder you could try to control for length of hospitalization before ICU admission when you were looking at that in the analysis. But there might be other factors that you just aren't aware of. Perhaps there is a standing antibiotic protocol to initiate new drugs in the surgical ICU that doesn't exist, and you may not be aware of in your medical ICU. There might be factors related to just provider preference that will be hard to control for. So lots of things you want to consider. It's obviously not ideal, but this is a methodology that you can use, and many people have done this. There are actually drug studies that have used non-randomized controls. They call them external extemporaneous control groups. So this is certainly a valid method and something to be considered, although it does have lots of limitations you just want to be aware of. And I know we do get asked this all the time from stewardship teams specifically who just aren't aware that you actually can do these comparisons. The key is you just want to be sure you have someone who is skilled in helping you do the analysis that will control for the confounders. The last of the different study designs I wanted to talk about is the most common quasi-experimental study design, which is the interrupted time series. This is a fancy term for classic before-after studies. So there is an intervention that is implemented. We'll talk a little bit about some fancy ways that you can start your interventions in a moment. But there's a pre-intervention and a post-intervention group, and the changes in your outcome of interest are analyzed to look at immediate changes you might see, and you can also get the effect of time. So you may see more gradual changes after implementation of an intervention. You can have control groups, and there are different ways to include those. I'll show a graphic of that in just a moment. That's also important. So here we randomize not at the individual patient level, but again at a cluster. So this, a great example of this going back to our meropenem targeted ICU round is perhaps you are going to roll this out and you have 5 ICUs in your facility. So you may be able to roll it out on the same day and still do the before-after for all of the ICUs at the same time. But you might be able to gradually roll this out across your different ICUs. And that's where we get into step wedge. So you can see here on the left-hand side of the slide is interrupted time series. You have your rates, you have the intervention started on a single time point, and you compare the before to after. You again want to try to control for things that may otherwise be occurring. Some of that need to control for those confounders can be addressed with the step wedge design. Again, this requires a more detailed analysis on the back end, but it is something that you can do, and it's very helpful to help scale up a stewardship intervention. And quite honestly, it follows the natural course of many stewardship program implementations. So you start, in this example, our cluster we're randomizing at is hospitals, and you start out with the first hospital or group of hospitals that start in the first month of your project, and you use that first initial rollout of your ICU rounds, using our example again, and you follow those patients, and you learn a lot from that implementation that then you can apply to the next implementation group that will start later. Unlike our cluster randomized crossover design, the group that you start in first, group 1 here, continues with the intervention. You don't interrupt the intervention. It goes on continuously. You just add more groups into the intervention group as you go, and then you can compare to the groups that started later, and everybody gets compared to the baseline period. So it's really quite nice. It does follow a normal, natural progression of many stewardship interventions where you try it out, see how it goes, maybe you pilot into medicine patients, see what happens, and then move it down to the surgical ICU once you've learned some nuances of having the face-to-face interactions, or who's going to staff the rounds, or maybe you use the initial group in your stewardship program, the initial rounding perhaps in your MICU to justify more resources to be able to expand to other areas. All very common ways that we see interrupted time series deployed, and because it does follow so much the natural progression of any stewardship intervention, it's nice to know about this, and you can do some prior planning and talk to statisticians and your analytics team to help you, 1, be sure you're getting the correct outcomes measured as you go, and 2, be sure that you have discrete enough time points in your plan. What is key to any of these, but most importantly in a quasi-experimental interrupted time series, is that you have good records of when things happen. And I think that that's another limitation that we see sometimes when we try to implement our stewardship interventions. It's sometimes hard to recreate the timeline. So another part of that very, very important planning of your intervention and your plan to disseminate the results of your intervention is to be sure you have concrete time points. And this happens to everyone. I'll tell you, this happened to us. I was part of a citywide stewardship intervention when I was up in Rochester, and we were rolling out interventions across a group of nursing homes in the city. And when we stopped and wanted to try to assess it more scientifically, it was really an interrupted time series with a step wedge implementation that had occurred. The problem is everyone sat around the table and nobody could remember exactly when things were implemented. You know, knowing that it happened in the spring of 2015 is not good enough. You needed to know, oh, we rolled that out on March 20th. So it's very important to consider the timing of any of your interventions for all these different study designs that we've mentioned, but especially when you look at the quasi-experimental studies. So be sure that as a stewardship team, you have very concrete records of exactly what happened and when, especially if the intervention you're trying to study is multifactorial. Now, that was a pretty quick review, again, of those various study designs, and I think it's important to know what they are, know how you might want to do your analysis, that you can talk to someone before you start gathering your data. But you also want to have some more planning that goes in before you implement. And where this comes into play is having things like good definitions. You need to sit down and not only identify what your outcome of interest is, but define how you're going to measure it. This is an example of a data dictionary from one of our actually infection control studies that I pulled. But specifically define what is our outcome, how are we going to decide if patients had or did not have the outcome, and where are we going to pull each very specific piece of data. This is something that's so often missing. It is a required element now, according to the consort guidelines. If you want to be able to publish your work, you maybe ask for this, but you need to define everything meticulously. We can't say enough how important this is to our various projects we have going on. And it also really helps the stewardship team think through a lot of the pitfalls you may run into if you're trying to recreate this data on the back end. You know, sitting down and saying, all right, I want to look at the length of therapy for meropenem, and I also want to look to see if we're changing the total ICU length of stay. Stop and think, where are you going to get those measures from? Well, how are you going to measure that for each patient? Are you just going to measure it from the time they started on their meropenem, or are you going to measure their total length of ICU admission, for example? It causes you to be more objective about those discussions. I find that this is an exercise we do a lot with our pharmacy residents. We have them have very robust data dictionaries, and it's very interesting. Even though we go through that process, I can't think of one project I do where they don't come to me about 5 patients into data collection and say, oh, I know this patient doesn't meet our definition for the outcome, but they're so close. Can't we just count it anyways? Can't we just say that they actually had microbiologic eradication, even though they don't meet our definition? So it's important that you define them, write them down so others can refer to them and use them if they need to, and then stick to them once you've had those definitions put in place. Very important part. And one step beyond what many stewardship programs do when they're implementing an intervention. So that is a quick overview. I'm not quite finished yet, but I definitely want to open up for discussion. Before I do that, I want to make everyone aware of some additional resources that are available to help you. So one is a series of white papers that Shay has released. This is the lead-in paper to that. These are research methods in healthcare epidemiology and antimicrobial stewardship. Goes through each of these different study designs in more details, in addition to the paper I mentioned by Jessina and JJ, which is also a fabulous resource. And then there's this group who oversees the strobe statement. The statement is actually a series of checklists for various observational study designs. It goes into details of things that need to be present for study designs such as case control and cohort studies in order to be able to disseminate them, which is the whole goal of this is to strengthen the publications around these observational study designs focusing on epidemiology. Very relevant to what we do in antimicrobial stewardship and a tremendous resource if you're someone who is looking to take your stewardship interventions to the next step and looking at pitfalls for what may prevent it from ultimately getting published if certain things are missing, such as definitions or good definition of the control group or a nice timeline of when your stewardship interventions are rolled out. That's all included in those checklists. You can see the website there. There are lots of documents as well as publications cited on that website. So it's a tremendous resource and we use it all the time. So I encourage everyone to look further. I'll also put a plug in. Shay does run a course on antimicrobial stewardship research if you're interested. It's the same course being run 3 consecutive years. It started last year and will be held this November in Chicago if you're interested. It's easy to find on the website. So in a short period of time, it's always hard to cover everything that you need to be able to disseminate the results of outcomes related to your stewardship interventions. But I think what we need to do is add a few more steps into the traditional stewardship team process. The first is you're still going to identify your problems and meet and come up with a good intervention. But from there, you need to pause and be sure you plan your outcomes and give tight definitions to the various aspects of your intervention and the timelines for that. From there, you can go out and come up with a good education and implementation plan and get your stewardship intervention in place, get going, start working, and then begin to measure your changes. And that hopefully, like many stewardship outcomes, you will see good success and be able to celebrate. But then, instead of having a pit in your stomach when someone says, oh, we should take this forward, and you know you don't have good metrics and outcomes to take it to the next step, you'll actually be able to disseminate it either through professional meetings and hopefully ultimately in the medical literature that's so very needed around all of our stewardship. For 20 years now, there has been a criticism of antimicrobial stewardship that we lack a lot of outcomes work related to the various interventions beyond just changing in the early days costs and more recently just overall antibiotic use. And I think that what I'm hoping is as more stewards get involved in this and I find ways to incorporate more formalized scientific assessment of their interventions, they will also disseminate it. Kavita Trivedi has a great quote from several years ago in response to why there's not more literature about antimicrobial stewardship outcomes. And the gist of it is that the reason is that most people are too busy stewarding to disseminate the results of their work. And what I hope we can do is make slight modifications to how we do our stewardship work that make at the end, dissemination of those results easier for all, because we need to see those results of all the valuable work going on out there every day by stewards in hospitals of all sizes. And practicing in all different types of patient populations, because it's so important for us to really define what best practices are. You see this represented in the level of evidence recommendations in the most recent stewardship implementation guidelines. It's hard to find high-level, high-quality evidence for various interventions outside of things like pharmacokinetics. So we really need to work as stewards to disseminate the results of our stewardship interventions in a more scientific fashion. So hopefully today's webinar has helped you with a little bit of that. I'm always happy to take emails and follow up, and I'm going to turn it back over to Marnie to moderate the discussion.
Terrific. Thank you, Libby, so much for a lot of information there that you covered, and I think it provides a lot of insight onto the different approaches. I want to also remind our participants that are listening today, please send your comments or your questions via the chat box to all panelists so that Dr. Dodds Ashley can provide her expertise on those questions. So I would like to ask you a few questions. It seems to me that the category interrupted time series is a very common approach that's utilized, and often people are trying to monitor their stewardship programs. You know, maybe it's just within one hospital, within 1 or 2 units. So, and I don't know if you find that or not, if that seems to be a very common design, but my question is the baseline. Sometimes it seems that it's either a retrospective analysis that occurs, or what you're proposing potentially is that you actually just track information for a period of time. And so I'm curious as to how long should that period be? You've got 1 year in your example. Is that a normal time period, or can it be shorter?
Yeah, so that is an excellent question. There is no universal answer to how long those time periods need to be, but you do need to be sure that they're sufficiently long. So sometimes when we design them, we can go as short as a month, but it usually needs to be longer than that to see changes. It really depends on the type of change that you're trying to affect. So if it's something where it's education and you expect provider behavior to change slowly related to your stewardship intervention, then your time intervals need to be much longer. And you want to be sure that you have enough time to measure those immediate changes and then gradual changes that may come as a result. You don't want to cut that off too early, because you may miss some of the changes that happen later on as there gets more widespread adoption or acceptance of the type of stewardship intervention you're having. You also brought up, is it okay to sort of rephrase your question, is it okay for that baseline period to be retrospective? And when I talk to people about this, absolutely. But remember, a lot of times what we're using is prospectively captured data in a retrospective fashion. So usually, whatever mechanism we had to identify the quote-unquote problem was in place in measuring, and that was often something that you're going to continue to measure and track over time about the changes in your stewardship intervention. So if the data is captured in the same way, even though you're going back to look at it, that's very valid to use. So lots of times we have ongoing surveillance of our antibiotic use, for example, and we identify a trend in that, and even though maybe we identify a problem we want to address in January, we still have the data from the prior year because we've been monitoring it the whole time. And so that is a very valid baseline period. So I don't want people to think that if they try to design stewardship interventions in a way that you can disseminate the results, that you have to see a problem and then sit on your stewardship intervention for a year. I hear that from people all the time. Well, Libby, I can't wait. Because I have pressure from the hospital, I have pressure from the providers to make a change in a positive way on this. I can't sit and wait on data for 6 months or a year to have enough baseline period. And usually that's not necessary. As long as you have data that you have been collecting in a similar fashion, or you can get those data, you can go ahead and implement your stewardship intervention, and you don't have to wait through that baseline period. You can do that. You can use prospectively collected data in a retrospective fashion.
I think that's very helpful for people. Another question is, looking at some of the clinical outcomes. So you're trying to determine, is your implementation having an effect on overall patient quality, mortality, readmissions, et cetera, that you've got outlined. How long do you also track that?
That's a good question. So sometimes some of those metrics, those sort of balancing measures that you're talking about, have a natural timeline defined because of the way we capture them for other purposes. So what comes to mind is 30-day readmissions. I mean, whether or not that's useful related to your stewardship intervention can be questionable, but certainly might be a balancing measure that you want to capture. Same, with length of stay. Sometimes we look at 30-day mortality rate. So sometimes there's a natural definition. Again, there is no one universal answer, but what you want to ask yourself is, am I tracking that long enough that it is reasonable that I should capture it? So if you're looking at C. difficile after maybe you switched an antibiotic regimen at your facility and you want to see if you're seeing more C. difficile in the patients who got the newer regimen or newer type of therapy compared to the older protocol, you would want to look at least probably 60 days after receipt. So you want to assess each outcome you're tracking and see what is reasonable that it would be related to the stewardship intervention or the antimicrobial therapy they received. For some it can be longer, and some it can be quite short. It just depends.
Okay. And a question that we have from one of the participants is related to, it kind of goes back to the article published by Rebecca Moehring and team, along with yourself. So some of the group 1, ready for immediate use and tracking outcomes, were days of therapy per admission or the days of therapy per patient days. Also a question to say, do you have a preference with days of therapy for the days that they are present, like within your particular unit?
Yes, so it was an astute listener who picked up on the fact that you may have noticed, so days of therapy was the numerator that the panel selected to go forward as the best way to measure antibiotic use. But the denominator, patient days, made it into group 1, so ready for immediate implementation because feasibility is there. Our infection prevention colleagues track it. Days present is the denominator that the CDC uses in the NHSN AU module. And there are tremendous benefits to being able to put your data into that and get some risk-adjusted data back out in terms of your antibiotic use compared to national hospitals, the comparator group. So I'll tell you what we do in our network. We are actively working on getting all of our hospitals converted over to NHSN, and we are actively reporting for about half of them right now. And so once we get all of our hospitals up and reporting, we will switch to the days present denominator. But right now, just so that we have some comparative data, we do use patient days. I think what's important is to know that there are differences between patient days and days present in terms of total number. There are particular areas where that is more emphasized than others, but you need to be sure that you are comparing apples to apples, and there's a lot of misunderstanding about the definitions of the two denominators. So my biggest advice is I think you can successfully use either to track the interventions related to your stewardship program. You just want to be sure that there aren't changes in method to how you're doing that over time. Because if one results in a greatly inflated denominator, it may appear to drive down your antibiotic use without actually resulting in a change, just a change in denominator. So very important to know what you're using and be confident that the methods that are being used to calculate it don't change with time. We spend a lot of time on this, and we really can't emphasize that point enough. It's very important to really take a hard look at what people are calling patient days and days present, because there is some confusion about that.
Okay, thanks for clarifying that. That's very helpful. So I kind of want to take you back to you've got your new residents, your fellows or new faculty that want to begin their antimicrobial stewardship intervention project. And it appears to me that if we are starting to enhance our research methodologies in tracking the outcomes and planning the studies for ultimately a dissemination or some sort of report, that you talked about you actually need, when you bring your team together, you need statistical support for this in the planning.
Yes, in many cases, yes.
Where do you get that?
Oh, that's a great question. So a lot of it depends on the type of analysis you're going to be doing. There are groups, usually at many hospitals there are groups that can help. If you're at a center that doesn't, our community hospitals reach out to us to help design their studies. We have some, so for example, we have a hospital in our network where there are medical residents that rotate through, and one of those medical residents wants to do an assessment of a stewardship intervention regarding penicillin allergies they're putting in place, and they reached out to us and said, can you help us? And so it's actually a pretty straightforward analysis, and we were able to give some guidance and teach a little bit on statistical packages that could help do those assessments. I mean, some of the methods we talked about, when you start having to control for a lot of confounders and do a lot of modeling, it does require some expertise that you may not have locally. But usually the local schools have someone who's willing to help. We find limitless students who are looking for projects who are happy to work in various settings that bring that. What you get with the student is you get the expertise of the faculty member or their mentor along for the ride, which can be a great resource to help you. I know this is something that people struggle with, but I also encourage individuals to go out and seek training. You know, there are some online courses that can help you at least ask better questions so you can streamline what you might be asking for a resource. And we found that in many community hospitals, there are actually small grant programs that might even get a little seed money. You know, you might be able to get statistical consult from a local community college or maybe not even that close a university that can help you remotely for maybe $1,000 or $1,500. And I have seen several stewardship programs successfully apply for and receive that type of money to give them the statistical assistance that they need to take their assessments to the next level.
Yeah, I asked that question just because if you plan your outcomes and really the shift that you're going to see is not a particularly large shift, it's still absolutely meaningful, but it gets back to your point of what the total number of patients you will need to enroll in your implementation. That can affect your time period. So if you're trying to get a total number of patients to have a statistical impact, show a statistical impact, significance, you may need a large number of patients, and that may increase your total time of study, correct?
Absolutely, yes.
Yeah.
Looking for small differences can greatly increase your sample size.
Yeah.
And, you know, sometimes I tell people the p-values, try not to be too hard on assessing the impact of your stewardship intervention based on the statistical analysis alone. I mean, there are lots of times where maybe you get a big data dump and you see statistical significance, but there's not a lot of clinically meaningful change. And so always, don't ever take that hat or that role out of your stewardship team. Always still assess them for, did it help? You know, is this helping patients in the way we need it to? And there may be things that your stewardship team does that are very valuable that will never have a p-value of less than 0.05, and that's okay. I don't think that we want to move to a world where we entirely decide what we're doing in stewardship based on significance or not. But I think that it is important to start looking at those methods to assess change more systematically when we can. But I don't want, you know, I would hate for people to say, oh, we decided we had to stop doing that because we didn't see a statistically significant change, because many of the stewardship interventions provide a lot of clinically meaningful assistance to the team caring for patients on antibiotics.
That's a good point. Thanks for clarifying that. A comment from a participant is, I think this is probably happening to several people, is that they've implemented a stewardship program and now they have been able to obtain days of therapy, but they had no prior days of therapy data prior to that implementation due to whatever electronic medical record limitations that they have. So what would then at that point be an optimal way to measure your program's success?
Well, so there's lots of different things you can do. I am guessing that there was some measure of antibiotic use before you had DOTs, and so perhaps what you do is, even though it's not perfect, you continue using that measure. We have lots of hospitals that when they first get the ability to measure days of therapy, because it takes a while to build up the time trend, maybe they were using defined daily doses or antimicrobial starts beforehand, I encourage them to continue tracking that for a period of time until we feel comfortable abandoning the legacy data and moving over entirely to the days of therapy because we have enough history data there for us to assess. I think it's important to not give up that historical trending that you've had for a while to be able to look at what differences you might be seeing. So what were you measuring before? That might be a great place to start. It might not be your ideal metric, but that's okay. It'll get there with time. And then I think there may be instances where if there's a very specific stewardship intervention that you're doing, you might have to go put pen to paper and do more manual extractions around that in the immediate time period to be able to assess changes if you don't have days of therapy historically. I think one of the biggest examples is when you're converting from a paper MAR to an electronic MAR. It's very difficult to get the days of therapy before. That would be a manual calculation. But lots of other things, be it, like I said, defined daily doses, antibiotic starts, are ways for you to look at that and assess it. And some will even try to correlate what those ratios might look like between the old and new metrics. But again, very hard to do anything with that when you don't have both metrics for the historical data. But look at the data you do have available, and maybe do try some point prevalence methodologies or whatever you're using beforehand. See if there isn't a way to turn that metric into an assessment of the stewardship program. Use the data you have whenever you can.
Can we also switch gears a little bit, Libby? I think you've given us some really great guidance here, and I'm just curious how can this be applied to if some of our stewards are in long-term care facilities? Is this similar, or are there specific tailoring that you do when you work within those settings around research?
Yeah, so we've spent a little bit of time looking at antibiotic use in long-term care facilities, and there are a lot of similarities, but some notable differences. So one of them is that their antibiotic dispensing there is much more similar to a retail pharmacy than it is a hospital with perhaps cart fill, for example. So we've had to switch our mindset a little bit. Some are now getting an electronic MAR, but we often don't have that, so we have to look at dispensing data and go by that in terms of what might be going out to patients. So that also introduces the unique challenge of the refill. So not every time we see an antibiotic dispense with a new prescription, it is sometimes a refill of an older prescription. We see this a lot around things like dental prophylaxis, where we'll see refills dispensed every time the resident has a dental visit. We also see more patients in this setting, for obvious reasons, on chronic antimicrobial therapy. And so that's where, if you're using that metric I mentioned of antibiotic starts, so new antibiotic prescriptions, so it's easy to do in the hospital because it's new orders. We have long-term care facilities where they may only have 2 initiations of nitrofurantoin, but in that facility, so for a year, they only have 2 initiations of nitrofurantoin, but they have over 600 days of therapy because it's, in each patient it was initiated and it was continued for an entire year. So just some nuances to looking at their antibiotic use just because of the long lengths of stay that residents have in long-term care facilities. But all in all, a lot of the differences are very similar. You can't use so much transferring to higher level of care unless it's actually to the hospital, because they don't do a lot of transfer between units for residents in long-term care facilities. But a lot of the metrics are very similar to what we use in the hospital. They lend themselves quite nicely to long-term care.
So Libby, when you're at conferences and you're looking at abstracts or you're reviewing manuscripts for publications, what are some of the things that you feel people, maybe you just feel like they just didn't quite do correctly that could be enhanced? So I'm just thinking of helping the listeners to avoid any pitfalls when they go to submit their manuscripts.
Yeah, I think the biggest missing element that we see that changes abstracts getting accepted or not is really failing to do anything to account for confounding. We looked at these 2 different groups. They were very different, and we didn't do anything to control for the differences we know about. You can, and based on those study designs, you can't control for things you don't know about, and that's just going to be a limitation of certain study designs when you don't use randomization. But when you know that there are differences between the groups, or there are likely differences between the groups, and nothing was done to try to account for that, I think that is one of the biggest limitations. And so that's really where stewardship teams can put a lot of planning into who am I going to compare to, how am I going to compare, and how I'm going to do it in a way that makes the groups appear most equal at baseline outside of the stewardship intervention. That's going to be really where I think you're going to get the most value for your planning time.
That's excellent. And could you just maybe make a comment of what would be kind of what you feel are some very common confounders that people miss? I think so sometimes I see the confounder of seasonality and antibiotic use just not addressed. So the way we actually do that is often we compare, year to year, November to November and not November to June. That's a huge problem. I see that a lot of times. They're like, oh, we looked at 6 months post pre and 6 months post, but antibiotic use naturally during this time can be very different. And so
one way that you can try to represent that is to show what overall antibiotic use was historically, and maybe if there aren't seasonal differences, or maybe the flu came late that year, so actually things look pretty similar, or whatever the reason is, just being able to assess that. I think that's one that I commonly see missed. Differences in testing that might have occurred. So we see this a lot. The most common example there is a change in C. difficile testing, and people don't account for that. Differences between providers, the education effect. We know that when we start training providers about using antibiotics optimally, they carry that forward to other patients. And so being able to either address that or identify that as a known issue, because providers may rotate from service to service or may rotate on and off service. And, you know, maybe they come in on one team and then they come back on a different team that may or may not be randomized or receiving the same intervention can be an issue. But I think those are some of the big ones that come to mind.
Yes, thank you so much. Well, unfortunately, we are out of time now, so we need to close our webinar today. And I'd like to thank Dr. Dodds Ashley for all your insights. And just to remind our participants that this webinar was recorded and will be available on our CIDRAP website under our webinars tab. And thank you very much for all your support. Thank you, Libby.
Thank you, everyone.